This is Dr. John Weston, and I'm happy to be here tonight and share with you some interesting information and hopefully have a little fun at the same time. I know we got people signing in from all over. I want you to know a little bit about me so that we can kind of make this format a little more personal. I practice in La Jolla, California. I have a multi-specialty group at Scripps Center for Dental Care. Very fortunate to practice in a specialty group setting where I can do my restorative care and the specialist around me can see the patients in the same location. Saves them time and energy and a little bit of money, and we can do really neat, comprehensive specialty care and comprehensive care. So really having a lot of fun doing that. We've got we're very fortunate to be in an area where we have military and just a really nicely well-rounded community. I happen to be an ex-Navy officer. Spent my time did a GPR and then went active duty in the Navy for a few years and kind of got my grounding there in dentistry and learned a lot. I currently own and direct the specialty center, Scripps Center for Dental Care. I've been here almost 20 years now. Very involved in the AACD. It's the largest cosmetic dental organization in the world dedicated to education and cosmetic dentistry. Do a little bit of lecturing and publishing on directs, on ceramics, and some digital technologies, digital impressioning, things like that. And then really just like to have a little fun too. I think it's important that in dentistry you don't get too serious and that we actually do get a chance to have a little bit of fun and spend time doing things besides working on teeth. So I tend to do that. I live near the ocean, so I'm able to go and do things that are related to the ocean. Spend a little time also over in Hawaii, which is really fun. And this is called kiteboarding. I love to do a little kiteboarding. It's basically like wakeboarding. You're just flying a kite instead of riding behind a boat. That's kind of neat. Also get up to the local mountains a bit here in Mammoth. Do a little snowboarding. This happens to be what we call carving, which is actually hard boots on a board. It's a lot of fun. It's kind of a racing sort of setup or GS type setup. I do a little underwater photography, do some diving, underwater photography, really enjoy that. This happens to be in Curacao, but I enjoy doing a lot of photography here on the reefs in San Diego and California and Catalina and places like that. And lastly, get to do a fair amount of surfing here in La Jolla. We have waves all the time on the reef, so I'm doing quite a bit of stand-up surfing nowadays because I'm too old to compete with all the little guys on the regular board, so do a lot of stand-up surfing. So that's kind of what I do. I think it's important that you try to have a little bit of fun and not just spend all your time working on teeth. Dentistry is a challenging profession, so it makes it nice to just get out there and do some fun things. Well, let's get into our presentation now. I gave you guys just a little bit of intro there just to kind of break the ice. I do want to give you a disclaimer. I don't make any money off the products that I talk about. This is actually what I do in my practice every day, and I've been doing for a number of years. I've modified some of the things I do with the advent of newer materials. But when I was asked to present this webinar, there was no restriction on what I could present. I just want you to know this is kind of the way I do it every day, and I've been doing it, and I'll keep doing it this way until I find better techniques or materials. What we're going to be talking about mainly is just posterior restorations, and I'm really into efficiency and predictability. So I'm a little bit careful about the newer products. I don't like to just jump on board and use something just because it's new, but if there's some science behind it, and it looks promising, then I'm definitely going to use it. So sometimes faster is not always better. But efficiency is important in dentistry. Patients want to be taken care of as quickly as possible. They want to basically, get in and out, and have minimal cost, minimal discomfort, and be able to really just get the service done and know that it's going to work. And like I said, it's things that I do every day. This is a typical case that you guys see. Patient comes in the door. You're doing your exam. You see a couple of old amalgams. We know that amalgam is a very excellent restorative material that's been around for many years, and some of us may still use it. But the bottom line is, what we do in my practice is we do a lot of amalgam replacement, not for the reasons that you would think of, not for the reasons of mercury or anything like that. We basically look at amalgam as a material that lasts pretty well and sometimes outlasted the tooth. And in a lot of cases, you can see fracture lines and stain around amalgam. There's a lot of reasons to replace an amalgam without having to go into the whole mercury discussion, which we just don't do very often unless a patient asks about it. So bottom line is, a patient like this might come in, we'd show them this on the screen, and we're going to spend a little time later talking about how to increase your patient acceptance when you get to stuff like this. The economy is a little bit different than it was years ago, and people were coming in and asking to have everything just replaced. Now they want a fairly good reason to have that done. So I think I make a point of giving them, a lot of time to see something like this in their mouth, and I let them ask me, how I can help them, and then we offer a solution. It's a pretty straightforward case. I'm just going to show you kind of how we approach it. You can see on the first premolar, there's a nice little crack on the mesial. The marginal ridge is definitely compromised. The restorations, while some might do indirect restorations on these, this is going to be direct restorations for me every day of the week. There's some marginal micro gaps along there, and definitely some evidence of micro leakage under these. It doesn't mean there's decay, but what we do see is more of a structural failure, just like you see on the mesial of that premolar. So once we get this prepped out, the biggest challenge when you take out sometimes these metal fillings is that you'll find cracks and stain, and you've got to get most of that out to really evaluate the tooth. You don't want to see any fracture lines down at the marginal area in the bottom of the box, and you want to get rid of most of the stain. You don't want to have to remove stain dentin if it's solid and if it's structurally okay. There's a big controversy. Do you remove all that or not? I tend to use the old-fashioned scratch test. I just take an Explorer and I go ahead and I just lightly scratch that surface so that I can tell if it's affected or not. You can use stains if you want to do that. There's a lot of ways to test those areas to determine if you've got decayed surface there. But bottom line is, you want to get a nice, hard, clean surface. Doesn't mean the stain's going to be gone. And then what I'll first go to in a restoration like this, where they're very deep, when you have an area like this where you're near the pulp, at least for sure on that second premolar, we're going to go ahead and think about using a resin-modified glass ionomer liner. And a lot of people, not everybody does this because it is an extra step, but I think on these deeper restorations, there's some evidence out there that shows a benefit here. So I'm going to talk a little bit about that and when I use it and when I don't. What I've done here is just taken a micro tip and I just snip off the end of the tufted micro tip, and I use this as a placement device. In the old days we had an instrument called a dical instrument. It had a perfect little bend in it to place your dical, which is your calcium hydroxide. Now we're basically I just use this little tufted instrument, the little tufted tip, and I just cut that little tuft off, and then I use this as a placement device. And we'll go ahead and just place that in on the pulpal floor right away, and then go ahead and once that's placed, we'll place it just on the pulpal floor. Go ahead and light cure it, and again, it's a resin-modified glass ionomer. We're not using the powder liquid traditional glass ionomer setup. You can do that, but now they have these available in a clicker type format with an A and B, and you can mix it up. Place it on the pulpal floor, and then we'll go ahead and place our matrix and etch. So this is kind of the device we're using for dispensing. This happens to be a 3M product that I like using. It's Vitribond Plus, and it's easy. Click out what you need, mix it up, and place it. A really nice material. Basically, what has been shown in these deeper restorations when you place a resin modified glass ionomer is that basically you can affect shrinkage in a very positive way, and they did this seeing what would happen with polymerization shrinkage when you place a liner like that. And what they found is that a less rigid composite resin or application of kind of an elastic intermediate layer like a Vitribond or something similar results. As a result, you basically have when you place your lower elastic modulus materials over that, you have a better marginal integrity. And when you have better marginal integrity, you're going to see, basically a healthier restoration that's less sensitive. So there's been a lot of studies on that, and basically what I do is I go by the science and I read about it. Glass ionomer is a very stable material, dimensionally very stable. And it allows us to kind of, anything that I can use to reduce the stress on the tooth and decrease sensitivity on a deep restoration, I'm going to do it. So like I said, I'll place that, and then I'll go ahead and get my matrices in there and etch over the top, and this is what you end up with is a nice etched sort of enamel and dentin, and the surface of that Vitribond is etched also. And I like to, again, I reserve this, for my cases where it's a little deeper. If you need to go in and clean up this area with a burr, you can do that before you place your matrices. I don't like an open sandwich technique. I'm not placing this on any enamel margins down there or using it as a margin subgingivally. I'm still gonna etch and bond down there, but for me, it's mainly just a pulpal type protection. And I'm using the Trident system here for rings. And then what I'll do next is go ahead and place a flowable composite as a second layer on top. I like a flowable composite because I get a really nice adaptive first layer. That flowable goes into all the little imperfections of the prep and all the corners that I have trouble getting a packable material into. So I'm going to place a thin layer of flowable material. And this is where you can use maybe an opaque flowable. They make really nice opaque flowable materials, and we'll use that to place over those dark areas. One of the things that happens when you're placing composite restorations and taking out old amalgams is you have very stained dentin material underneath, and then you'll replace this restoration with a nice composite material, and you'll see the gray through that composite. And there's two problems with that. One thing, sometimes the patient can see that and they'll ask about it. The second thing is, on recall, you're not sure what's going on underneath that restoration. You don't know if there's continued micro leakage or if there's recurrent decay or anything like that. So I like to block out that dark area. So I'll use an opaque flowable material underneath there, flowable composite, to sort of block that out. You could go ahead and use a packable material too that has a high density or a nice opaque, let's say a dentin layer or something like that if you want to do that. I just happen to like this flowable. I use the Filtech A3O. It's an A3 shade opaque flowable, really nice material, and I'll place that in as my initial composite layer. And then we'll go ahead and go in and I like to use, I'm using Filtech Supreme Ultra. Again, this is a 3M system I'm using when I do these composite restorations, and it just happens to be, what I've dialed in on over the past, 10 years of just trusting 3M as a company. And it's more not so much about using that particular product, but nano composites in general are really taking over the market, and there's a big reason for that. I mean, obviously we've used hybrids for years. Herculite was one of my favorite composites for many years. But there is a distinct difference between a hybrid composite and the particle size and a nano composite. On the left of the screen, you can see an SEM of Filtech Supreme Ultra, which is their current nano composite. And the particle formation is very different. Nanoparticles are very small little balls, and then they're clustered together in these clusters called nanoclusters. And the difference really is in the size. Typically, on a typical hybrid, you might have particle sizes even up to 1 micron. With nanocomposites, and not just 3M, but most of the nanocomposites on the market, you're going to see particle sizes in the 1/1000 micron range, which is really wonderful. What you end up with is a material that gives you, essentially the strength of a hybrid, but the polish of a microfill. And we all know the advantages of a microfill. Microfills are something that I still use in my practice for a lot of Class 5 restorations and things like that. And it basically is a wonderful material, but it doesn't quite have the flexural or compressive strength of a hybrid. But it polishes really nice. So these tabs that are laying on this screen basically show you what the material looks like, what some of these materials look like after about 6,000 cycles of simulated brushing. And this is after they've obviously been polished. And the ones on the left are your nano composites, and then you have your handful. And the one that's closest actually is the microfill Renamel, which is a wonderful microfill that a lot of people use, and I still have in my practice. So nano composites give you that kind of advantage of strength and polishability, which is really wonderful. And a number of companies are producing really nice nano composites. So that's what I'm using. And then I'm going to go in and basically build these restorations with 2 more increments. I don't get all crazy and do cuspal buildup on these because, again, I'm trying to, you see these articles about these wonderful recreations of molars with composite. I think it's exciting and super fun, and it's sort of inspiring in a way. But the bottom line is I'm in a practice like you, trying to generate an income and be efficient with my time. And so I've narrowed down to doing these buildups kind of facial and lingual cusps is what I dial into, and I'm gonna ramp that material first on the facial cusp or the lingual cusp and fill it in, and then go ahead and apply it to the lingual cusp. I'm not going to do a corner by corner type situation because I want to be efficient, but also I'm concerned about issues with contraction. And one thing that can happen if you just fill that up and bulk fill that whole restoration and then cure it hard. There's a situation that develops called C factor, and that's the stresses that are incurred by pulling those 2 cusps together when you cure that restoration. So one of 2 things is going to happen. You're either going to get stresses inside the tooth that are internal, or you're going to get marginal breakdown of the material at the bonding surface, and neither of these are good. So by filling one side at a time and curing it and then filling the other side at an angle, for me, that's my sort of quick, efficient way to reduce C factor. And there's a bunch of articles about this. I mean, you just go online, there's a million different articles out there that talk about C factor and how to do that. But the bottom line is, we spend all this time treating that tooth structure and that surface carefully to create a proper hybrid layer to make sure that we get a good bond, and we follow the manufacturer's instructions on the adhesive material. And then if you go in and slam in a bunch of composite all at once and hit it with one of these high intensity curing lights, you're going to get micro gaps and debonding and stresses, and you can sometimes create significant sensitivity for the patient. So it's important just to follow some basic rules. And so I do that by doing the ramp technique. And once the one side is filled against that cusp, I'll come to the other side and fill the other side and go ahead and cure it and clean around these matrices, and then I'm basically ready to clean things up and kind of finish the restoration. So kind of a simple technique for me. I place like I said, if it's deeper, I'm going to place Vitribond. Then we're going to use an A3 opaque flowable. Then we're going to go in and do one cuspal side and then the next cuspal side and finish the restoration that way. When I get into doing my finishing and polishing, I've kind of been playing with these new spiral wheels. These things are really fun. The nice thing about them is all the surfaces are impregnated with abrasive, so you're not there's not an area that doesn't have abrasive in it, and you can manipulate these to fit into any sort of part of the tooth. They go interproximal, they go occlusal, so I'm not switching between cups and points anymore like I was to get my polishing. So I really like these new materials, and this is kind of what it looks like when you're using them. You can really get these abrasive little tines to go down into places you just couldn't get with a cup or a point, and then you could use it interproximal too. So there's 2 of these. There's a more abrasive one, a finishing one, and then a polishing a wheel. So I really love these things. I am going ahead, and when I really want a super high polish, I'm finishing up. If this is an anterior restoration, I'm finishing that with Cosmodent's product. It's a purple felt wheel with a little bit of enamelize to get a nice super high pop shine on that. But for my posterior work, most of my occlusal type restorations, interproximal, class 3s, things like that, this is great. You can just use these two wheels and get exactly what you're looking for. And then we'll go ahead and go to the polishing wheel. And same thing, you can run these things all directions, and they just kind of fit in and float around and really get all the surfaces really nicely. I'm really liking this product. It's kind of fun. There's our final result. Get in and do a little flossing around those, and make sure you've got your proximal contact. I'm finding with the Trident system, I'm getting a really good, nice proximal fit and contact point. Not really any issue anymore nowadays with getting open contacts with composites, because I'm not using a Toffelmeyer setup any longer. I'm just using the preformed matrices, and there's a couple of these systems on the market. Garrison makes an excellent system. Trident has a great system. Composite, I think, or there was an original one that we used to use. I can't even remember the name of it, but when it first came out, a ring and matrix system. So these are great. They're great systems, and there it is in the mouth, completed. And I always take a before and after for patients, and we show this to them because we want them to see the benefit of what we're doing for them. And patients, they love to see it. I mean, patients, when you do nice work for them and you show it to them and you don't hurt them and you do it efficiently in a timely manner, they'll pay their bill. Happy patients pay their bills, and that's what we're looking for. We're trying to be efficient and make money, at the same time. So I think it's important to show a patient. Most of the time I'm using the intraoral camera to do a before and after chair side, but I also will shoot with the SLR occasionally. And we do something unique in our practice. We take photographs of our patients. We just do 3 photographs. We do a retracted view of the upper and lower teeth, just straight on retracted view, and then we do occlusal views. And we do this as part of our exam every year. We take this occlusal upper, occlusal lower, and a retracted straight-on view, and the team members do that, so it's ready to go. And it allows me to have discussions with my patients. So let's get into case study 2. It's a very similar setup, and I just want to go through and just show you kind of what we would do that'd be a little bit different. And I'm going to talk about how you can gain a higher acceptance rate with restorations. One of the things as dentists is that we talk too much, and a lot of times you'll get a patient like this in the chair, and here's typically how it would go. You'd say, okay, Mrs. Jones, here's what we've got. You've got these 2 old fillings, and you can see all around these fillings there's some cracks and stain, and they're a little bit gray, and you instantly follow that with, and what we need to do is go in and take these restorations out and replace them with composites and make these teeth all pretty, and you'll love it, and the patient just thinks, okay, how much is that going to cost me? And they're not really engaged in the process. Really what you want to do with a case like this, and I want you to try this next time you go to your office, get your photograph like this, whether it's an intraoral picture or your SLR or whatever you're going to do to show, because you got to be showing patients the conditions that you're talking about. Put this on the screen and just show it to them and let them see it. And say, Mrs. Jones, you've got these 2 fillings here on these 2 teeth, and you can see around the edges, you see these little cracks where the tooth looks like it's actually splitting apart. And the reason that happens is metal fillings, they're a great material, and we all used them, for years, but what we found is that they expand and contract at a different rate than the tooth does. So over time, as you drink hot and cold liquids and things like that, you're going to see cracks that form in and around these restorations, and that allows micro leakage or leakage around the filling and the gap to form, and bacteria get in there, and this is why you're getting the black stain. And the concern is that a little piece of tooth might chip out of here, or you might actually crack the tooth all the way through the center. And then what you do is you stop talking, and you just have a few moments of awkward silence. So you tell her, anyway, and you say, and this is what can happen is you can end up with little cracks, and you may even end up splitting the tooth right down the middle. And then you just sit there like that in silence. And what's going to happen is the patient's going to look at that, and it's going to be a little awkward for about 15 seconds. And then they're probably going to say, what can you do to fix it? And that's the moment that the patient becomes engaged. And if they don't say anything and you wait 10 seconds or so and it's a little uncomfortable, you can say, that doesn't look very good, does it? Those are really, not looking very good. And most of the time by that second comment, they're going to say, what can you do to help me, doc? How can you fix that, doc? I mean, what would you recommend? And then you go, I know exactly what I'd do. And you tell them, you say, you know what we need to do? We're just going to clean those restorations out. We'll numb the area, clean those restorations out, trace out these little cracks, clean everything real well, and we can go in and flow in an epoxy-like material that will kind of glue your tooth back together and protect those areas from getting worse. It's not a guarantee that it won't crack, but it's definitely better than what you've got now. And we know that bonding works, so it's a great solution for patients. So that's kind of what I would recommend, is that you just stop talking and don't give them the answer until they ask for your help. And that's the most important thing, I think, when you're talking about treatment planning, whether it's a big case, small case. This is one thing also I want to talk about is rubber dam. I place rubber dam on teeth. I don't do a whole quadrant. I just do one tooth on either side of the place I'm working, just to get in there and be able to work fast and efficient. And I tell the patient, hey, I'm going to place a little rubber shield on. It's going to keep all this old metal from going down your throat and keep the area clean and dry so I can do a nice restoration for you. And this is kind of what the preps look like. You can see that we've gone in and just kind of literally cleaned out the amalgam and traced out the few little cracks that were there. I don't get real excited creating giant boxes anymore and things like that. I don't really have to. I feel like with the newer materials, you can go in and create really, really nice conservative type preps using small burrs and things like that. I use a little pear-shaped diamond burr to do this. And I like doing these little, very conservative restorations. If I don't have to remove the enamel that's healthy, I try not to, and I'm very careful with that. And I think it makes a big difference when you can go in and do conservative dentistry and preserve all this tooth structure. So I'm doing this more often than not. And so these were pretty small occlusals, so I'm able to go in and do that kind of minimal tooth reduction. And then what I'll do, where I have these tight areas where basically maybe where I didn't create a complete box, but I want to clean in there really well, I'll take a Brasseler diamond strip and just run that along in there. This is a perforated strip, fine diamond. You can get these from Axis or Brasseler, either one. This is a yellow stripe fine diamond. I'll go in and just kind of clean that area real nice and clean, smooth it up, get rid of any excess loose enamel that's in there, and just set myself up for a really clean bonding surface. Sometimes I'll even pull that strip through and just slide a little clear strip in there, or I'll just pull this strip over to where there's no perforations and just leave it as a matrix. So a couple different options to do that. And then we go in and do a complete etch of that area. Now I'm doing total etch. I'm actually not just selective etching the enamel, but I'm doing a total etch of the dentin and the enamel, and about 10 seconds on the dentin and 15 seconds on the enamel, and then just go ahead and completely rinse it. And then you end up with a really nice, you should have a nice frosted look to that enamel, and the dentin should appear clean and slightly frosted too under loops if you look under that on magnification. So bottom line is this is what we're looking at. I did slip a little matrix in that distal, but all these other areas I didn't really need to do any kind of matrice because I can get in there and clean this really well. So that's a total etch system. Now I am using for my adhesive, I am using one of the new universal composites. This happens to be the 3M that I'm using now, but there's a couple of companies out that have really nice universal adhesives. And what they mean by universal adhesive is you can use it for a multitude of scenarios. You can use it for a total etch, for a selective etch, or as a self-etch scenario. The advantage of having etch in your adhesive, it comes down to the hybrid layer. What happens is you're basically creating your hybrid layer at the same time you're hydrating that dental surface. And what has been shown is that there's a lot more freedom, or it's a lot more forgiving when it comes to having dry dentin or moist dentin. You know, a big question I always have is, how moist is moist? You know, they talk about, well, don't over dry the dentin, don't do this. Well, you know, how much moisture do you want in there and how much do you really have there? So what I do is I like to etch and just kind of pretty much dry things out, and then I go and rehydrate. And I'm rehydrating. I used to rehydrate with Gluma or Tubulicid Red. Now we do a rehydration with our universal adhesive because we're basically hydrating that dentin as we're applying the adhesive at the same time we're etching that surface too. So I'm really enjoying using this product, and I think you'll find that the research out there supports using these newer adhesives with at least at minimum selective etching the enamel margin. So the research still shows that we're not getting as good a bond on enamel as we could by etching it. So doing 2 steps and go ahead and etching that enamel at least is helpful. And to keep it simple, I just etch everything, because some of the other data shows that we can get a little bit of increase in strength by etching that dentin. Not much, but enough. So, and it's simpler to me, if I'm going to etch enamel, how do I not etch dentin, and how much do I want to etch? And I've just found that the sensitivity rates are so low with this with the new adhesives that I'm not worried about etching that dentin at all. So I'm going to do a total etch, and then we're going to apply this adhesive with agitation throughout the prep to make sure that we get a complete agitation. And here's a little chart that talks about self-etch, and how it compares. And the bond strengths are in the 20s and 30s on all these systems that are out there right now, which is really nice. And that's in a self-etch mode. If you're going to go to a total etch mode, you're going to get nice performance as well. And so I think that it's important to understand why we talk about etching and what parts we should etch. And I think at minimum right now you want to definitely etch enamel margins for sure on these restorations. If you're in an all dentin scenario where you're basically using it as a build-up material or something like that, I think it's fine to consider just using a self-etch, the self-etch side of the system, and just if you're right on dentin, then just go ahead and self-etch. If you're going to be anywhere on enamel, it's nice to have a little etching. And what the research also shows is, like this case, I didn't actually place, if you noticed, I didn't place any Vitribond. And that's because there's a fair number of articles that talk about there's really a minimal difference in hypersensitivity in posterior restorations when it comes to your sort of average depth restorations. So when you're talking about posterior composites or posterior fillings, if you're talking about moderate to average sort of depth, placing a glass ionomer liner didn't really prove to show a huge difference in sensitivity. It's only when you got a little bit deeper into those dentinal areas where you're pretty close to the pulpal chamber. So in my practice, I don't do that extra step with the Vitribond on every single restoration. I use it for the deeper ones where I know I'm close to the pulp. And on the more typical restorations, I'm just going to place my flowable material, my flowable composite, as my first layer of composite. And that's what I did here. I used an A30, and this is one of the articles that I referenced that I was able to find. So we're going to place that flowable as the first layer, and then we're going to go in and do our ramp build-up technique to reduce C factor. We don't want to create a lot of stresses on the tooth, so we're not going to bond this adjacent cabo surface at the same time. Now, one of the other things that I do to help to get this material to adapt, this is a packable composite that I'm placing in a Woodson plugger. I like to use a snowplow technique where we basically place a little dab of flowable composite and then place our packable on top, and then as we squeeze the packable down, the flowable kind of fills in all the little spots that I didn't quite get adapted properly. So it eliminates that situation where you can have small little voids and things due to the difficulty of manipulating packable composite in real tight areas. So that's one thing I do, is I'll place a little dab of flowable and then put the packable on top. And then we're going to go ahead and place it on the adjacent side, the adjacent cusp, and use that same instrument to kind of ramp it down and get it adapted well. And for me, I used to spend, quite a lot of time, forming the anatomy and getting everything just right on these posterior teeth, and I would get these teeth that looked anatomically wonderful, and then I would take everything apart, and the patients would say, "Why does it feel so rough to my tongue?" And they really complained about the roughness, and they want a smooth, kind of slick feeling tooth that's just functional. So I've kind of leaned back more toward making teeth that are, occlusally in good function. Centric occlusion is set up properly, and they're smooth. There's not a lot of, secondary anatomy. I also do not place stain in the grooves, because every time I did that, and I showed it to a patient, they would say, what's that stuff in there? It looks like there's decay in that tooth. Did you actually fix it? So I don't do that as often. I tend to make a nice white clean tooth that's nice and smooth. I also want to talk a little bit about curing. It's really important. We sort of take curing for granted, and curing lights have changed dramatically over the years, and now we have these really intense LED curing lights that are wonderful. But it's important to understand, a lot of these lights, I used to think that curing for 3 increments of 2 seconds each to create a 6-second increment, or 3 increments of 5 seconds each to equal 15 seconds was the same as doing 15 seconds at one time. And recently I heard a really nice presentation by Joe Oxman from 3M, and he was talking about the minimum curing time that they've determined is really ideal, right around 10 seconds and not less than that. And doing 2 5-second increments is not the same as doing 1 10-second complete cure. So when it comes to curing, I've just set all my lights on 10 seconds after reading some of that information, and as long as your increments are not 4 millimeters deep, 10 seconds is going to be just about right, and has shown to be real effective. It's also important that the head of the light is at a perpendicular angle to the composite. You don't want to have this tilted off at an angle. You're going to lose a lot of efficiency. So I like to actually do my curing, so the assistant just hands the curing light right to me. I stick it right where I want it, and that just makes it easier for me. But it's easy to train assistants to do that properly also. And then here's kind of what we end up with when we're done. And I think one of the things that can happen, you'll know if you're curing adjacent cavo surface margins and you're doing it at the same time. If you notice on both of these cases, we don't have any really major white lines or anything, but if you see those white lines along your restorations, more often than not, that's either a contamination of your adhesive material with saliva or something like that, or it's a stress factor that you've created and you've bonded both sides. And when you see that kind of white line forming, it usually means you placed too large of an increment and maybe you connected it to the other side, and when you cured, it shrunk and pulled, and it creates a little micro gap. So one of the things you'll notice when you start curing, one side at a time, or one cusp at a time, or buccal and lingual cusp, you might say, you're going to see less of those white lines form, and that's really nice. It's a great feeling because you're doing a better job. So this is kind of right after curing. You can see a few little places where it's dehydrated, and you can see the margins, but overall, a nice result. And then what I do with the matrix, you notice how we left this matrix in and we bent it backwards. This is just a little trick. I don't go in and yank all these out of here, and if I have multiple matrices, a lot of times I'll just fold them in reverse like this, so I can go up and trim with a burr. It allows me to get in there and trim around these teeth without damaging the adjacent teeth. So a lot of times I'll even sometimes leave these interproximal. And you can take your flame diamond and go right up in there against that tooth. You can carve with a blade. There's a lot of ways that you can get in there and sort of do trimming by leaving these matrices in there. So now I leave these in place and do all that kind of preliminary trimming and make sure that I've got everything right where I want it. And then the only 2 burrs I use when I'm doing my finishing is the flame diamond and the football diamond. And these are a red stripe flame and football diamond, and I use it basically to get all my contours. And it's a simple way, for me, I just keep my armamentarium very simple, very clean, very straightforward. It allows me to basically not have a bunch of instruments out. And I like the fine diamond because they don't load up. Carbide burrs for me tend to load up with material, and they kind of skip and jump over the surface. So I like to use diamonds for that reason. They're just a lot more, for me, it's a cleaner sort of cut, a lot smoother. And then I can go in with my finishing products and get a nice smooth finishing effect. I also sometimes will use a number 12 blade and go in with a curved blade and just kind of clean around. That's another way you can do it. And when you're using a 12 blade, it's nice to have a matrix in there to work against. So that's another way that I'll do it. And then we'll pull everything off and do our occlusion check. And I don't go crazy on occlusion, but one thing I do always look for is I want to have nice centric occlusion either on the functional cusp tip or right on the marginal ridge, and I like to see adjacent molars come into contact. I don't want to see anything over on the non-working side, so I'll make sure there's no interferences on these non-working cusps. I want to make sure that the occlusion is centered right on these functional cusps, and that, it's not too big. I mean, I want to keep it. It's amazing how patients will they'll pick up even that contact. Sometimes you'll have a patient who will say, it still feels a little high, and you'll dust that off, and they go, oh, that's perfect. They almost don't want to feel it at all. So sometimes when you're adjusting occlusion, I think one of the things you can do is when you go to remove a spot, don't remove the whole spot, but just make it smaller. But make sure it's on functional surfaces, marginal ridges, things like that, and take it off of your non-functional areas. And even if you want to, you can even have them do some chewing motions. And sometimes we'll sit patients up and have them chew a little bit. And I tell them, hey, focus on the side that we didn't numb. Do a little bit of chewing, and you'll be surprised the contacts you'll pick up when a patient goes into a chewing motion that you didn't get when they just tap. And I think that's critical because, every time a patient has to come back for a bite adjustment later in your practice is just one more little mark, and in their mind they're thinking, hey, this wasn't quite done perfectly. So we have very few patients come back because we do set them up. We dry the area. We have them chew on a piece of carbon paper, and then we look in there and check it out. We use the AccuFilm, and we do that. So we've reduced a lot of our follow-ups that way for bite adjustment. We've also seen a significant reduction in patients returning for sensitivity after going to our self-etching adhesive and using a selective or total etch technique, because we know we're getting a really nice hybrid layer on that tooth, and that's going to really reduce your sensitivity. And then on your deeper restorations, obviously using your Vitribond or your glass ionomer liner is going to be huge for that on your deeper restorations. And then again, we go in to use our spirals. I love these things. Again, this is the finishing one, and you can see how well it adapts to those internal surfaces. Really, really sweet. And it'll go interproximal too, so it's basically a nice way you can send it interproximal. You can use them on the buccal lingual surfaces, and it just kind of gets in everywhere. So I'm really liking that. And another view of just how those things kind of fit, how they fit in there really nicely and just adapt to those surfaces really well. I used to go round and round. I've gone with I've used flexi discs. I've used rubber cups and points. I've actually gone with pumice and prophy cups, and we just tried a whole range of things. But I think for my bread and butter dentistry, quick, down and dirty, get it done, and patients are happy, I think having a system like this where you're just literally, I have 3 burrs. I have the pear-shaped burr to cut the prep. I have my flame diamond and football diamond, and then I have these 2 finishers. So we literally have 5 burrs to do posterior composites, and that's all we have on the setup. And we really have a slick system down for doing that, so it's not a lot of jumping around. This is kind of what you get when you're done. It doesn't give you the super high gloss, but it gets you a nice beautiful satin finish that's real clean, and basically a real smooth sort of to the patient's tongue, real smooth. And again, when I take the rubber dam off, the patient puts their tongue up there and they feel back here on this restoration. And they tell me, they'll say, oh, it feels really rough what you just did. And I'll say, which tooth feels rough? And they take their tongue and they put it back here on this one. And it's not even the one we worked on. And I say, oh, we didn't work on that tooth. We worked on the ones up forward. And they feel that and they go, oh, that feels really smooth. Can you make the back one smoother? So again, and I'm sure you've heard those comments. So I think the point is that I'm typically making anatomy that's really smooth and clean and looks and feels good to the patient, and it's functional. And I'm not putting in a lot of the fancy, secondary anatomy and things like that. It just hasn't been something that's, paid off for me every time I've tried it, or any time I've added stain. They've always asked, why is that there and what's going on. So for me, keeping it simple is important. And so I think we're really close. I think we're just a couple minutes early, but we can go in and start answering some of the questions. Looks like we've got almost 20 questions here that we'll start going through. So I wanted to have time to go through those questions, so I went a little bit faster. So let's go in and answer some of these questions that are up here, and we'll open this up a little bigger. So let's go, and we'll start down here. Oh, people are asking, usually they were saying, I had some people commenting about the water being cold down here for diving and surfing and stuff like that. And no, it's great. We love the water out here in California. So somebody, I think we get into this first dental question was, I want to get the sequence correct. Do you place the glass ionomer first and then etch, or do you etch and then place the glass ionomer? And basically what you want to do is you want to go ahead and place your Vitribond or glass ionomer first. Then you want to etch. Then you go ahead and place your whatever primer adhesive. Again, the etching can be selective just for the enamel, or it can be all enamel and dent in the total etch. Then you place your primer adhesive of choice, whether it's a 2-bottle or single bottle, and then you're going to place your flowable and then your packable composite. And the only thing I do that I would put in there is I use a little dab of flowable under each increment of packable composite just to get a nice adaptation. Next question was, do you prefer a liner of composite flow with the glass ionomers and the release of fluoride and the coefficient of thermal expansion similar to Denton with ionomers? That's a little bit of a tricky question. Bottom line is, I do like a glass ionomer, like I said, on the deeper restorations. It's a very stable material, and it's going to help with dental sensitivity, and it's going to release fluoride. So I'm going to use, like I said, a glass ionomer under a deeper restoration. I'm going to use a composite flowable liner under all my sort of moderate to routine depth restorations. Another question here asking about which packable composites do I use. I pretty much settled in on the nano composites. I use either the 3M Filtech or the Heraeus Venus nano composite. So those are the two I'm pretty much using full time now. Here's a question about do I like sealers on the composites like Fortify? You know, for me, using sealers was a little bit problematic because I would get the occlusion just the way I wanted and get everything set up. And then the theory is you're supposed to etch that surface and apply this Fortify over the top and then cure it. And then what happens is you've affected your occlusion again. So now the patient sits up, they bite down, it doesn't feel right. So then you go back in, you have to polish all that off. So I just found placing composite incrementally allows you to get a really nice result, and polishing it well. You don't have to worry about the margins if you place it incrementally, and if you polish it well, it feels nice to the patient. So I'm not using any of the sealers or covers. Somebody was asking what rubber in a clinical case 1. I'm not sure what that question is. Maybe you could send that back. Something about what rubber was I using or something like that. I'm not really sure. I'm going to go through a few more of these questions. What's the lifespan of this restoration? That's a good question. I mean, I'm telling patients 7 to 10 years is what I tell patients, depending on how they take care of their mouth. You know, if somebody wears a bite guard and brushes well and doesn't let a lot of plaque build up, and they're not chewing ice all the time, it's going to last longer than somebody who's more abusive. But I think it's easy to probably tell a patient, 7 to 10 years, and really the wear characteristics of composites is very similar to that of amalgam. So as far as the actual tested wear rates, I think what comes down to it is, are you using a rubber dam? Are you keeping the area dry? Are you using good bonding technique? Are you etching your enamel margins? Things like that are going to give you a longer clinically serviceable restoration. Then somebody asked about Theracal, if I'm using any Theracal or calcium liner. I'm not using any of that right now. I think the place where you would use that is if you had a near pulp exposure or even a slight pulp exposure. That's where Theracal might be beneficial, but I'm typically not using that. What I do is I just etch that surface to sterilize it, and I'll place my glass ionomer over that area and then go ahead and do what you basically saw in this presentation. There's a question here about for cracked enamel, how do you remove cracked enamel? I use, when I get into cracks and stuff, I'm definitely using some loupes or a microscope to clean those cracks. Let me see if this question expands a lot. Yeah, they're just asking how I remove that cracked enamel. I just trace those out with that diamond burr. I think if you use a diamond burr, you're going to have less material breaking away. Sometimes you can get a lot of material breaking away when if you're using a carbide burr and you start going through a crack, you can create so much vibration that you can actually cause that tooth to shatter a bit more. A diamond burr is going to cut a lot smoother, and I have a lot better luck tracing out fractures and things like that when I'm using a diamond burr. There was a question if I ever used Di-Cal in deep restorations before glass ionomer, and the answer is no, I don't do that. I think if you had something that was that deep that you were thinking about using Di-Cal, I would probably go to a TheraCal, which is a more current, a more modern material, and it has the same effect. And somebody here wrote that down. They wrote use TheraCal instead of glass ionomer. Yes, I do I would have it in the practice. I don't typically reuse it routinely, but I would on a very, very deep where I have a small pulp exposure, maybe indirect or even direct pulp exposure. I'd probably use TheraCal. So another question, do you cure the flowable composite before applying the packable? Yes, I do as a first increment. I'm going to place just a really thin layer of flowable in the bottom of the restoration, and I'm going to tease it into all the corners with an Explorer onto the pulpal floor and into the corners around the matrice in the difficult areas. I'm going to place that flowable in there as just a top layer, and I'm going to cure that. And then each layer of packable that I place in after that, I'm going to go ahead and use a little dab of flowable under each layer of packable just to help fill in the spots underneath that piece of packable as I push it down. It's called a snowplow technique, and it just allows you to sort of fill in all those little micro porosities around that packable piece of material that you placed. And we cure that all at once. So the flowable, if we're using it in a snowplow technique, it's going to stay uncured, and we're going to kind of push it around with the packable composite, and then we're going to cure it all at once. Asked about Sonnet Fill. We do have Sonnet Fill in the office, and we're kind of playing with it. I'm being a little bit careful with bulk filling systems right now, just because of what we talked about with C-factor and some of the research, and they're pretty new systems. So I'm just kind of seeing how that goes. I like how they go into the restoration. I like how it's placed. I'm not really a fan of having more hardware at the chair, but I think it's got some promising aspects to it, so I'm going to keep an eye on it. I can't really give you a lot of answers on that right now. Somebody said here I like using the wedge as a barrier, or not using the wedge, but using the matrix as a barrier. They like that technique. Kind of bending it in reverse, that's a neat idea. Somebody was asking about one bottle systems. They have practice he joined recently has a one bottle system, etch, prime, and bond, and he was taught to do etch separately. I think they're right. There could be a compromise with a one bottle system if you don't etch the enamel. That's the only area probably where there's a little bit of a compromise. So I'd make sure that you're etching your enamel margins at minimum when you're using a single bottle etch, prime, and bond. And make sure that the system allows you to do selective etching. That's something that you want to make sure you read on the instructions. Most of them will allow you to do that. Do you find, let's see, matrix system? There's a question here. Do you find the sectional matrix system works well for quadrant dentistry? Otherwise, doing multiple restorations back to back. And yes, what I do is sometimes I'll go ahead and place all the matrices and the wedges and the rings, and then I'll build one of the restorations and make sure it's in there nice and solid, and then I'll build the other one against it so I can push that matrix and re-burnish it against that adjacent tooth. But yeah, I don't find a problem doing back-to-back MODs as long as I'm careful to build one side of the mesial and then build the distal against that, if that makes sense. So, and then they were asking, are nano glass ionomers, is that as good as a nano composite? What's happening with nanotechnology is it's starting to be introduced into all parts of dentistry because of the ability of having very small spherical particles, and you get a lot of strength, and you can have high fill rates with products. I am using a Keytac Nano. It's a nano product, a resin modified glass ionomer nano restorative material, and I do have that, but I don't use them in the same places. So I typically, like I said, I'm using the nano composite in high functional areas when I want to get a nice clean finish and have the patient function against it for a long time. I'm not using it as a final outer surface restorative material, except in areas where I have a super high caries index at the gum line of crowns that I'm refilling in geriatric patients, or in kids who have high cavity index, maybe on primary teeth. But I'm not using typically that as a final restorative in adults. Here's a question about bonding agent. Here's some studies. Somebody mentioned that some studies have shown flowable composite on the axial floor is equivalent to usage of Vitribond or other liners. What's your stand on that? I think if you can get a good etch and you get a clean surface down there and it's clean and it's etched well, you're going to get a nice dentin bonding strength down there with flowable, and you're just not going to get any fluoride release. So if you have a patient who's a high cavity index, you may want to consider doing a sandwich technique down there. But for me, I don't really put any glass ionomers at the cable surface margin down on the axial floor. I tend to use my composites. So, and a lot of people don't use any resin modified glass ionomers under any of their composite fillings. They just use flowable, and it's not really considered to be a liner at that point because it's composite. It's just a first layer of composite, and it's so I think it's really, the research shows, and like I said, your moderate to normal depth restorations, flowable's fine. If you're going to get into something really deep, you should probably think about placing an intermediate layer of a resin modified glass ionomer. It's just going to help you with the stresses that are imparted when you have those larger, deeper restorations. A lot of people thanking me for the presentation. I appreciate the compliments. That's great. Somebody asked if I guarantee my composite restorations. I don't really do that. I just tell patients, hey, this is a 7 to 10 year restoration. Depends on how you take care of it. It's just like your car. If you drive your car off road, it's not going to last. The tires won't last as long as if you drive it on the highway. So we just use very simple comparisons, but I don't really give any. I don't give any guarantees that way. A couple of people asking about, do I warm the composite to help it flow better? I don't feel like I've needed that, so I don't use a warming system for composites. I typically just use them at room temperature, which is about 75 degrees Fahrenheit for us, in the 70s range. And I find that's why I use a little bit of that flowable underneath to kind of help fill in those little voids and things. But there's nothing wrong with warming composite as long as you don't add any water to it or anything like that, if you're going to use a water bath or how you're going to warm it. There are some nice little composite warmers out there on the market that are great. If somebody asked about my burr armamentarium, if you just go to my website, I'll bring up that last slide again, and you can go to my web. I'll let you email me, and you can ask about the burr armamentarium. That's something that we can do. I think I have a here's my information right there, so you guys can get to that. Somebody was asking about intraoral cameras, things like that. Let me just go a couple more questions here. Let's see, here we go. Oh, that camera that I was using for the presentation actually is what I'm using right now for presentation stuff is a Nikon D7000, but the camera that I use chairside is the Acclaim camera, and it's a really nice camera that we're using. It's a USB type camera that interfaces with EagleSoft, which is a Patterson product, so I'm finding that works pretty well. And then there was one question here about polishing paste. What do you think about polishing paste on posterior composites? Like I said, for me, that final spiral tip is enough for me. But I think if you want to get into using paste and things like that, you're going to have to change over and use some kind of a cup or a brush to get that. And you could use a Diashine, diamond polishing paste, or there's a whole bunch of them on the market if you wanted to do that. Again, for my anteriors, I'm using the Cosmonet purple felt wheel with the enamelize. And one more question here. Would you repair a small void area or replace it? Does it matter if you leave some old composite base? Do you replace the old base liners under restoration? The answer on replacing anything old, if I'm going to take an old restoration out, everything's coming out. I'm going to go all the way down to the dentin, clean it really well, and I'm going to make that determination. If it's very deep, I'm going to place glass ionomer liner. If it's not very deep, we're going to go straight with a first layer of flowable. As far as, so we're going to definitely clean that. We're not going to leave any old stuff down there, because a lot of times it's old. It might be dical, it could be IRM, it could be something that compromises your bond that was fine under amalgam but doesn't work well under composite. And then it asks if you were to repair a small area on a large composite or replace it. I have no issue repairing areas on larger fillings if the rest of the filling looks good and it was placed by me, or it looks like it was placed recently. I'll go ahead and do a small repair. I don't think that's a problem. You do have to micro etch that composite that you're going to place it up against. So you might want to have a micro etcher chair side that allows you to micro etch that composite surface, so you get a better bond there. I think that's about it. Time's up. I appreciate everybody paying attention, and please feel free to reach me. You can reach me at scripsdentalcare.com or go to aacd.com. And thank you again.